Hello and welcome to another edition of Coffee with Polio Experts. I have with us here Dr. Zubair Wadood, Senior Epidemiologist for WHO, and we're going to be talking about polio eradication, particularly in Afghanistan and Pakistan. Dr. Zubair, thanks for joining us today.
Thanks a lot for having me on your show.
Our pleasure, our pleasure. So, can you maybe tell us, before we start, can you tell us a little bit about your background?
So, actually, Joe, I'm a medical doctor and a public health physician, epidemiologist, and I've been on the mission to eradicate polio since 2004 and started my journey in a district in Pakistan in the northwest of the country. But then I've been working with the country offices, mainly Pakistan, and then for the last almost 4 years I've been based in Geneva at WHO headquarters, supporting the countries in their efforts to eradicate polio and also ensuring I pay my contribution towards maintaining an interagency partnership towards achieving this goal.
Great. So, 2004, you've been in the game for some time now. Great. So, Zubair, we're looking at three endemic countries right now. We've got Afghanistan, Pakistan, Nigeria hasn't seen a case since 2016. But it's still on the endemic list. Maybe tell us how much progress do you think we've made in say, Pakistan and Afghanistan? How are things going?
So I think firstly we have to remind ourselves where exactly we are coming from. Since 1988, when this global resolve was made to eradicate polio globally, we used to have more than 350,000 cases globally, but if you go to Pakistan, for example, there used to be more than 25,000 cases. At that time, means that 25,000 kids were paralyzed for life. And if we look at this simple indicator, the number of polio cases now, for example, this year, 2018, there have been less than 10 cases. So, and the same kind of figures we have for Afghanistan as well. So I think it's a tremendous progress that has been made, but actually the fact of the matter is that we are working against a very unforgiving target, and which is zero, and not just a zero polio case, but actually extinction of the polio virus, and the word we used is eradication. So it's not a control program, it's an eradication program, and that's what makes it very challenging to achieve. So we have made a lot of progress, but even one polio case is too many, and we know we are getting there. It's the last bit and the last mile to go, but still another push required to make sure that we cross the line.
Right. So as you said, there's no margin for error. There's no missing the virus. We need to get rid of it completely.
That's correct.
Yeah. Okay, so maybe what are some of the challenges in these two countries in particular? I mean, they're the last, say 3 countries. The last countries left on the list. What are some of the obstacles?
So, first thing that we have to understand is that in Pakistan and Afghanistan, the situation is not that polio is everywhere. Polio virus is transmitting and circulating in certain parts of the country, where the program does face some challenges in consistently reaching all the target children and vaccinate them every single time a vaccination drive is planned. Based on the information we have and the data we collect, it's very clearly demarcated geographically which are those areas which are harboring the virus. Now, coming to the challenges, there are a number of challenges. But firstly, I must say that polio eradication is not really a rocket science. It's about reaching the kids and vaccinating them. If you do that, you stop transmission. If you don't, then virus continues to survive and transmit. So there are areas where the program has not been able to consistently reach the kids due to factors like access challenges due to insecurity. We know that there are parts of Afghanistan. The situation has improved in Pakistan, but there are parts of Afghanistan where consistent access to the children is a bit difficult due to insecurity and ongoing conflict in those areas. Similarly, there are certain operational reasons which affect the performance of the program, and there are difficulties at the ground level for health workers to reach every house and every child inside those houses, and that's where the virus continues to transmit and survive.
Right, right. And I guess, population movement, I heard that the border is something like 2,000 kilometers long between Pakistan and Afghanistan, and I'm sure, population movement between the two countries is a significant challenge.
Absolutely, that's one of the challenges that as I mentioned, certain operational reasons. One of the reasons is the population movement. It's very difficult to catch the children on the move, and as you said, it's more than 2,000 kilometers long and very porous border. We have formal, informal border crossings across a very, very long patch of the land, and it goes across provinces in Pakistan and Afghanistan. It's not just one small patch or a few patches where there is border. As you said, it's a long border, and it is difficult because it's not a movement that happens at one particular time. It's an ongoing movement due to multiple reasons. There are reasons like people move based on seasonality, winters to summers, summers to winters. Similarly, there are economic reasons, labor reasons, social reasons. People have social ties, social cultural ties across the provinces. The same tribes, same group of people living on two sides of the border. They have relationships, so they move. So I'll give you a very concrete, specific example that if a vaccination drive is planned in the bordering area of Pakistan, and some of the kids living there move during that time to Afghanistan, and a campaign or a vaccination drive is not planned on the other side, it's difficult to catch those children, and of course, it's difficult to catch them while they're moving. So that's definitely one of the reasons, and the information and data does indicate that these mobile population groups are playing a very significant role in having the virus continue its transmission. I think what I'd also like to refer to is the experience in the past, where the Indian polio eradication program. India, we know, is now out of the list of the endemic countries, and that's a huge success, actually. But towards the end stage of Indian eradication efforts, India did also face a significant problem with achieving consistently high coverage among the children on the move, and there were multiple strategies that were used then to achieve that high coverage among these population groups before India could stop the transmission.
Right. Great. So maybe what are some of the what are some of the initiatives? What are some of the targeted interventions, or say operations that are happening to address some of these challenges? So, for example, you mentioned families living on both sides of the border. What happens in terms of campaigns? What happens in terms of tracking or finding these populations and reaching kids on the move, say, or families on the move? What's the program doing?
Yeah. Now that's a very important question, and that's exactly what the Pakistan-Afghanistan programs are striving to achieve, is to make sure these kids are reached every campaign. Now, to start with, I must say that there is a very strong partnership between the two polio eradication programs now, that is the Pakistan and Afghanistan programs. And for the bordering areas, let me say that they are almost acting as one program, although we have two administrations, two governments, but it has been acknowledged by the highest level political administrative leadership that for polio eradication purposes, this is one epidemiological block. With millions of people and millions of kids moving on daily basis, you cannot disregard the other side of the border. And then it's a health intervention, a humanitarian cause. So there is a very strong partnership between the two programs. When it comes to the ground strategies, where the rubber hits the ground, there is very concise, strong, and in-depth micro-planning that the teams on the grounds try to do. Firstly, to mark the presence of these groups that have the tendency to move due to different reasons. And not just that, but also document and record the time on which they are, expected to move out of their houses or settlements, and the span of their movement, the routes they take, the border crossing, and then ultimately their destination. And based on this entire tracking information, then the drives are planned in a way that there is highest likelihood to reach these children with the vaccine. That's one. The second thing is there has been a strong network of transit vaccination teams put in place along the border on the two sides of Pakistan-Afghanistan border, where these crossing families are kind of intercepted and the kids are vaccinated while they are moving. And then I must say again that this huge movement is not just an individual risk, it's a public risk, because on one hand there is high likelihood that the moving kids or kids on the move would have higher chances of missing vaccination, but on the other hand, this mobile population can take the virus in their guts from one place to the other. I always say virus doesn't move by itself, but it moves with people. So, our genetic analysis clearly tells us that, the virus we find in Pakistan is genetically linked to virus found in Afghanistan and vice versa. And this ping pong kind of transmission of virus continues. So these are some of the strategies. And then additionally, the programs also try to train the health workers who have to actually reach these kids in a way that they understand and know the importance. And also they have very good interpersonal communication skills to deal with these families, because you would realize when a family is on rush, crossing the border, moving towards a destination, it's not straightforward to ask them to stop for a while and offer them vaccination, which is not a very attractive service actually. So the health workers are trained well, and then social mobilization drives are also run in those areas, just to make sure that the public and the masses there are aware of the importance of vaccination, and as I said, both the individual and public risks, so that when vaccination is offered to them, either their houses or while crossing the border, they tend to accept that service.
Great. So in terms of community acceptance, then, sure, you hear about people refusing the vaccine. How big of an issue is this in say, Pakistan or Afghanistan? We know that we've got vaccine hesitancy in Western countries. So what's the real situation on the ground in terms of that?
Now, what we hear while sitting here in Switzerland sometimes is refusals and hesitancy for vaccine. Public hesitancy for vaccine is among the biggest causes for not achieving polio eradication, which is not true. Yes, we do have some resistance in certain areas, but for example, I'll quote the example of Pakistan, where the kids missed due to the refusal of families is far less than 1%. the same figures we have for other countries. But not to undermine the importance of those kids, especially in situations where these families or these kids are clustered. So if the kids missed are sparsely populated or located, it is still a risk, but when they are clustered in one place, then it becomes a bigger risk because virus finds it's easy to transmit from human to human. But coming to the reasons of missed children, as I said, there are more operational reasons. One of the key reasons, for example, in Afghanistan is, as I said, difficulty to reach children because of insecurity. So there are kids residing in the eastern and southern part of Afghanistan, which are the two areas where it has been difficult to stop transmission. Not a major, but let's say a significant chunk of population lives in an area where running a drive in an efficient way, house to house, reaching every child, is difficult. And similarly, there are areas with not absolute inaccessibility, but there are concerns about security. The law and order situation is not really very good. So the teams do not find it very easy to go house to house and offer vaccination. But also, I think one important component of our polio eradication effort is providing the health workers with a good supportive supervision. So if the teams are going house to house unsupervised, there is likelihood that they would tend to miss a few kids due to one or the other reason. Let it be, some shortcoming in their intercommunication skills with interpersonal communication skills with the families, or maybe sometimes some performance errors, and these things can be overcome by providing a good level of supervision.
Right.
And having that provided in an area with bad law and order is a challenge. And similarly in Pakistan, I think I must say that the security situation and the kids missed due to access challenges has significantly reduced in Pakistan. Is almost close to none now. But the operational reasons that I just mentioned still exist in some pockets that lead to gaps in the vaccination coverage. And I must also say that achieving polio eradication in these areas is more challenging than few other areas in the world because of the environmental factors, because these areas in Pakistan, Karachi, Peshawar, are very densely populated areas. So in densely populated areas, the coverage bar to achieve polio eradication is not 70 or 80%, not even 90%. You have to achieve 95% vaccination coverage, and that also consistently over a period of time, 6 months to 1 year's time, you have to have consistently high coverage, high quality rounds, achieving very high coverage. So if it fluctuates, the virus gets the gap to go through. So these are some of the reasons, but the efforts are ongoing, and we'll continue until we cross the line.
Great. Maybe comparing this year and last year. This year, I think we've had 27 cases. Last year, there's 22 cases. What does that mean exactly? I mean, are we taking a step backwards? Are we stalling? What does this mean?
Actually, no. We are not stalling. Given the fact that we have made a huge progress that I mentioned earlier, a few cases here and there, a few cases higher or lower would not really mean a lot at this stage of the polio eradication program, which is the end game. This is statistically insignificant, I would say, unless there is a huge variance. If there is a big outbreak in a new area in Pakistan or Afghanistan, that would be significant. But if we have, let's say, a few more cases compared this year compared to last year, it's not that significant. Also, if there is a downward variance, if we hit the zero, no year in the entire year, then no case in the entire year, that would mean a lot. But these, as I said, few cases, a few more cases or a few lesser cases would not really be an indication of stalling of the progress. But what I would like to mention here, Joe, is that the number of polio cases is not the sole indicator. There are a number of other data that the program is collecting, and it's so in depth and so detailed. We have, you know, a very rich surveillance data being collected through a very comprehensive surveillance system across the two countries. Similarly, we have plenty of social data on behaviors of the community and the way they respond to the vaccination service, and so on and so forth. So there are a number of other indicators, and one indicator that I must mention is the genetic biodiversity of the polio viruses. So every polio virus which is isolated in the lab actually goes into a detailed genetic analysis and tries to match it with the other viruses. And this testing has been going on for years and years, and it indicates that the genetic biodiversity has declined significantly over the last few years,
right,
which indicates very, very significant progress. So in a holistic picture, in the last few years, we did make huge progress, and now that we are seeing a few more cases this year in 2008 compared to last year, it does not really indicate stalling, but it does indicate that the virus has actually moved through the cracks, and there is need to reach those unreached kids, which have allowed the virus to continue its transmission.
Right. Great. So we're on track.
We're definitely on track, and we are closer than ever before. And probably I can easily say that's the best chance we have at this moment since the start of the polio program.
Fantastic. Thank you, Dr. Zubair, and you know, as really insightful, and thanks for sharing, you know, your background and experience with us, and we appreciate you being here with us today.
My pleasure.
Great. And thanks to our audience for joining us. Join us soon for another edition of Coffee with Polio Experts.